Welcome to the Croghan Foundation Early Childhood Webinar Series, Neonatal Abstinence Syndrome Supporting Infants and Families. My name is Scott Melton, and I'm a continuing education planner here at MAHEC in Asheville, North Carolina. And I will be your host for today. For the best results during this program, we do ask that participants use a landline if possible, and please mute your computer speakers and microphone to prevent feedback during the presentation. Let me remind you that in order to receive credit for this session, you must be logged on a separate device with a personalized invitation sent to you by your email, and you must attend the entire session to receive credit. Your credit will be tabulated, and a certificate will be posted on the MAHEC MyCE area 24 hours after the conclusion of today's webinar. I'm mandated to report that this program was planned according to the standards of each accrediting agency, and there are no conflicts of interest. There will be a brief evaluation following the course that will pop up after the program is concluded. We ask that each of you take the time to fill this out. There is a section for physical therapists to include their name, credentials, and license number. If you're not a physical therapist, please just type NA in that box and complete the evaluation. You may also download the handouts of the session today in the handout section on your GoToWebinar menu or the MyCE area on the MAHEC website. All of the handouts and presentations will be hosted on that MyCE area for both sessions. So we've got a large number of folks on the webinar today. Glad to have everybody here. Due to the large capacity, if you have a question for Dr. Seashore today that you would like for us to present at the end of the webinar, please just make sure that you type that into the question box in the GoToWebinar menu, and we'll take the most common questions and we'll offer those up today. You can also type questions into the chat and the group during presentations, and sometimes some coworkers and other folks can answer those questions for you. We are recording this session today and for educational purposes and quality assurance. This is a jointly provided program with the Leo M. Croghan Foundation and the Mountain Area Health Education Center. So let's get started. For those of you who are joining us for the first time today, our speaker today is Dr. Carl Seashore. He's our presenter, and he is a general pediatrician and the medical director of Newborn Nursery at UNC Hospital. In his role, he leads a team of talented professionals, including MDs, NPs, pediatric residents, and medical students in caring for term and late preterm infants. Over the past 9 years, he has developed expertise in evaluation and management of infants at risk for and with Neonatal Abstinence Syndrome. During this time, he's partnered with the team at UNC Horizons program for pregnant and parenting women with substance use disorders, leading to innovative approaches to the management of pregnant women and their newborns. Dr. Seashore has been featured on WRAL and PBS NewsHour programs to help the public understand the nuances of neonatal abstinence syndrome and its impact on families and society. And now he's with us today. So please welcome with me Dr. Carl Seashore.
Thank you very much, Scott, for the opportunity to talk here today. And thanks everyone in the audience for participating. Look forward to some discussion and questions from the audience. And please use the chat features that Scott mentioned. We'll also have a few polls to try to get some audience participation scattered throughout the talk today, so please be prepared to answer those when they're presented in line with the slides. As Scott mentioned, I'm a pediatrician here in Chapel Hill at the UNC School of Medicine, and I work in the nursery setting where we care for babies who are at risk for neonatal abstinence syndrome, and also in the outpatient setting where we follow families through early childhood and beyond for ongoing care. So I have a lot of interaction with this patient population, and I work closely with our OB department, which will be one of the focuses of today's presentation. Okay, in terms of disclosures, I have no conflicts of interest or financial relationships to disclose. It's important to note that there's some subtleties around the labeling of buprenorphine and naloxone in pregnancy, and some regard it as off-label use, although others regard it and read it differently, as shown on the slide here, where They have been shown through very well done trials to be effective treatments for opiate use disorders during pregnancy. However, they should only be used in the scenario where the potential benefit outweighs any potential risk. And so pregnant women with opioid use disorders can be effectively treated with methadone or buprenorphine. And Dr. Jones has written that this should not be considered off-label use. However, not all agencies have caught up with that. So there's some nuance around that, and it's important if you're working with folks in the clinical setting to understand that. Similarly, the medications we use to treat NAS aren't specifically labeled for that, but they are the standard of care. I'd also like to add some acknowledgments to today's presentation. Dr. Andre Jones is the executive director of the UNC Horizons program, which I'll talk about a great deal today. That's a program here in Chapel Hill that is dedicated to the treatment of substance use disorders in parenting and pregnant women. And really the entire team at Horizons, from peer counselors up to Dr. Thorpe, an obstetrician who founded it, everybody on the team really plays a critical role in the care that we provide for women and babies. And without them, it would really not be a successful program. And lastly, the patients in the program, both the children and the mothers, who have taught me an incredible amount about addiction, about recovery and resilience, and just strength. It's really an inspiring population to work with, and I'm indebted to them for helping me understand the nuances and challenges of treating patients in this situation. So I'm grateful to them for what they've taught me. The objectives for both sessions, and we discussed these last time, are to have a better understanding of the characteristics of the neonatal abstinence syndrome and how we screen for and diagnose it, as well as listing appropriate interventions for infants who are at risk for NAS or develop more severe symptoms of it. And that's what we covered last time. Today, we're going to focus more on the features of evidence-based treatment for women with opioid addiction or opioid use disorder, and describe strategies for working with families who are challenged by addiction. And so these latter two objectives today are what we're going to be focusing on for the remainder of the talk. And I hope by the end of it, you all have a good sense of the tools and resources that are available, both locally in your communities and also online and in other outlets to help serve these families. Just to review very briefly, this was kind of the take-home messages from our first session. For those of you who were on it, I hope these are messages you've retained. For those of you who weren't, this is what we really hoped people would take away from the first session. So the Neonatal Abstinence Syndrome, or NAS, known also as Neonatal Opioid Withdrawal Syndrome, or NOWS, is an expected outcome of medication-assisted treatment in pregnancy. So that's the use of replacement opioid agents, long-acting, to treat opioid use disorder during pregnancy. It's a manageable outcome that is much preferred to prematurity or the other complications of untreated opioid use or substance use disorder during pregnancy. NAS typically presents by about 5 days of life and can last up to several weeks depending on the patient and the circumstances, and it's something that we can treat effectively in lots of different ways. And the other take-home point was that over the past several years, the evidence has shown us that non-pharmacologic treatment is really crucial. And that includes simple things like what the environment the baby is in looks like, the amount of noise, the amount of light, the amount of disruption, but also engagement and empowerment of the patient's mother in the treatment plan, and the education, both prenatally and in the postpartum window and beyond, of that mother to help her understand the things that she can be doing to help her baby have the optimal outcome. Because we know at the end of the day, all babies do better when they have, ideally, their mother or other parents and caretakers supporting them and helping them have optimal developmental outcomes. So I hope those are lessons that folks who attended last time walked away with. And those of you seeing this one first, know that those are all really important things that we think about when we're treating neonatal abstinence syndrome. So we'll introduce the first poll here, and I'll turn it over to Scott to flash that up on the screen, and I'll give you all a couple of minutes or a couple of seconds to respond to that, and then we'll look at the results of the poll together.
So here's the poll. It says, I work with babies who had or were at risk for neonatal abstinence syndrome as part of my job, and please, if you would, just select yes, no, or I work mainly with mothers. I'll give you guys a few minutes to get those votes in. All right, we've got about 84%. Give a few more seconds. All right, now we'll close the poll.
Excellent, thank you, Scott. So it looks like the vast majority of the folks listening into the call today have worked with babies at risk for or with neonatal abstinence syndrome, and not nearly as many of you work primarily with mothers or have not seen this. So that's great. I think an audience who understands and has personal experience with this challenge, the challenges of NAS is really wonderful to have. So some of what we cover for you all today may be review, but I hope the lessons still bring important content for you all to carry out of today's session. Okay, this is a slide that you've seen before if you were at the previous session, and I put it in again just to highlight that the treatment of babies with NAS and mothers as well is not something that can be taken on with similar effect and impact and outcome by a single person, whether that be a social worker, a therapist, a PT or OT therapist, a physician, a nurse practitioner, a midwife. Any of those individuals is not going to be as successful in treating a mother-baby dyad challenged by addiction as a team will be. And this is the team that I work on. The medical center here in Chapel Hill serves all 100 counties across North Carolina. We have about 4,000 annual deliveries here in Chapel Hill. And our standard of care for these babies, and all of our babies really, is rooming in care on the mother-baby unit postpartum. And it's important to note that our standard of care for babies at risk for NAS is the same as all other babies. They get to have rooming in care, and that mom-baby dyad is not separated unless there's another indication other than NAS for that. And then we're also home to the UNC Horizons program for pregnant and or parenting women with substance use disorders. And that program is internationally recognized standard for really what the gold standard of care should be for women with opioid use and other substance use disorders. So we'll dig into more details about what that program looks like as we move forward. Our women's and children's hospitals are connected. That's what's in the background picture there. It's a hallway that separates me from my hospitalist colleagues in the children's hospital and our neonatal unit and our PICU, et cetera. We do have a pretty large neonatal critical care center and then a large network of primary care offices in the region. So when I describe the patterns of care that we're looking at, it's important to recognize that we're doing that with an infrastructure of a whole host of different types of healthcare providers working together to serve these moms and babies. And so as you look around your own communities, think about who those team members might be, where you are on that team, and perhaps who's missing, and how you could find someone to fill that vacant role if it exists in your community. So the Horizons program really is built on the foundation of the model of family-centered care. And this is care that's delivered, whether it's the hospital setting or a clinic, that is centered around the needs of the individual family. So this might be what rounds look like in a hospital setting, or what a clinic environment looks like in an ambulatory setting, or what your physical therapy office might look like where a patient might be coming in for a treatment session, and making sure that that's welcoming to family members, that the people accompanying the patient, if it's a child, feel accommodated and welcomed is really, really key. And the motto of the Horizons program is healing generations. And what Dr. Thorpe, who founded the program, is fond of saying is that his mission is to break the intergenerational cycle of addiction that characterizes folks with substance use disorders. And that's accomplished through a multimodal treatment approach that involves treatment for mothers, and so specific evidence-based trauma and addiction treatment, the opportunity for residential placement for women with more severe opioid use disorders, or, I'm sorry, I'm getting a power warning here, so I'm just gonna plug my computer in somewhere else. Okay, hey, sorry about that, folks. Apparently the outlet I was plugged into was not connected to power, so this should be okay now. Apologies for that interruption. Residential treatment as well as outpatient care, depending on the severity of a woman's opioid use disorder. Their OB and gynecologic care needs are met. And then there's also psychiatry embedded in this program, along with psychology, counseling, and social work resources. And the women are given educational and employment training opportunities so that when they come out of treatment, which is typically the first year postpartum, they're ready to go out and join the workforce and become active members of their community again, based on the treatment they've received, addressing both their physical health needs, their pregnancy health needs, but also their mental health needs. At the same time, treatment for children is embedded in the Horizons program through child care services for preschool-age children, accommodation of kids up to age 12 in the residential program, early intervention services for the babies born during the mother's stay in the program, as well as those younger children who may come in with the mother, and then psychiatry services and mental health services for the children to address any needs that they may have beyond what the mother's needs are. So that treatment is really embedded alongside the treatment for mothers within the same program, literally under the same roof now here in Chapel Hill and Carborough. And so this treatment model of treating the mother and the baby together or as a dyad is then able to be extended to include parenting education, so teaching these mothers about how to effectively parent their child, maternal child dyadic psychotherapy, where the attachment and interactions between mom and child can be evaluated, and then simple things that can be sometimes complex, like transportation, so that moms can get to various needs they have in the community, be that pediatric care or the grocery store or other needs that she may have as she goes through treatment. So this is really, again, a woman-centered program that allows women who are parenting or pregnant to receive treatment without being separated from their baby. And so why is this important, and what makes this successful? Well, I think this is rooted in the unique opportunity that pregnancy creates to engage women in treatment. If you, as most of you know, if you have someone who is creating a neglectful or harmful environment for a child, then the state often becomes involved and may remove custody of that child from a parent if there is evidence of neglect or abuse. And someone with untreated opioid use disorder who is perhaps not adequately supervising their child may fit that paradigm. And so the motivation to keep their child, whether it's a young child they are already parenting or the child they are currently pregnant with, is a type of motivation that may not be present in other circumstances or for other patients. And so that opportunity really gives us a chance to work with mothers who are at extremely high risk at a time in their lives when they may be differently motivated to address their own needs. And it's important to know that these women have a nearly 10 times higher mortality rate than their peers without substance use disorders. So this is a disease with significant risk to life. And so treatment can be especially impactful if that's recognized. And that pregnant women who are using illicit substances because of the legal concerns may delay prenatal care or not address their own health care needs compared to their peers who aren't using substances. Again, putting that baby or that fetus at risk of not developing optimally in the womb or after birth. And so creating an environment where these women can be welcomed into treatment and feel safe really, in addition to improving the mother's outcome, has an enormous impact on the infant's outcome as well, and the pregnancy outcome in terms of decreasing the risk of prematurity or other complications of untreated substance use disorder in pregnancy. And then lastly, that prenatal care, again, will help mitigate those negative impacts, whether it's growth restriction. Again, prematurity is one of the more common complications, but also those related to hepatitis C or HIV infection and other comorbidities that may impact the infant if the mother is not engaged in treatment. And so that opportunity to engage mothers is really multiplied and amplified by the fact that not only is her health improved, but the health of her baby is also impacted in a positive manner. The lower prenatal care utilization likely is complicated and maybe issues as simple as transportation or the knowledge that prenatal care is important, but also those fear of child loss of custody and child custody issues is a key driver for these women. And so helping them work towards being less at risk in those scenarios is a part of the approach to treatment. Obviously, if the child is born and there's ongoing untreated substance use disorder, that home environment is not ideal and can create really detrimental effects on the child's growth and development, as well as their safety. There is obviously an increased risk of maltreatment or non-accidental trauma among children who are growing up around substance users. And again, if we can maximize maternal well-being while she's pregnant and parenting this newborn, that really more than anything is one of the key determinants that will optimize this baby's health outcomes and the health of that baby as they grow to be an adult. And again, that gets towards interrupting that intergenerational cycle of addiction that I mentioned earlier. And so who are these patients? And I think this is going to look familiar to many of you as you think about the mothers of the patients that you've worked with. This is a sample of 220 women who received treatment at the Horizons program between 2015 and 2016. So this is about 2 years old. But we have this comprehensive data for that cohort. The mean age is just under 30 years, so these are relatively young women. The whole of them are either uninsured or eligible for Medicaid. 72% have completed high school and have that level of education, with the others having less than that. A little over half are pregnant at intake, and the majority have at least one child under the age of 18. More than half of those with children have current Child Protective Services involvement before their introduction to the Horizons program. And the drug of abuse that's most common in this group is opiates, and that can come in the form of prescription opiates being used inappropriately or obtained illicitly, but also heroin increasingly over the recent years is common. About 20% or 1 in 5 are using cocaine or some derivative of cocaine. About 10% use alcohol, And the vast majority, nearly 90%, are current active smokers, which is a substantial confounder to the development of NAS. What I think of as a pediatrician more than anything when I look at these data is that the age of first use on average for these women was 16 years old. And so that's when they are my patient. As a pediatrician, I take care of kids well into adolescence. And so it's my job to be identifying the risk factors for substance use really upstream before that age, before that first substance use, and trying to prevent it. And so those of you who are caring for children, keep that in mind as you start to see kids in their early teens, that substance use is often appearing at that young age. The vast majority have substance use disorders in their family and or mental illness. And so those are common bedfellows. It's important to realize that these two things go hand in hand, and those substance use disorders have an intergenerational component to them. The majority, again, have been arrested at least once. So beyond CPS involvement, they have legal troubles. And on average, 4 arrests has been the experience of this group of women. And then these last several points I really want to highlight. Again, the vast majority, 84%, have experienced at least one type of interpersonal violence, be that physical, sexual abuse or assault, or domestic violence. Among those with sexual abuse, the age of that onset was 12 years, so at a very young age, and a third have attempted suicide. So this is an incredibly high-risk population who have had an incredibly challenging early childhood experience, going all the way down to their school-age years and early adolescence. And so being aware of that is really one of the core tenets I want to have people take home today. And what that is called and what that looks like is trauma-informed care. So I'm going to pause here for the second poll and ask Scott to go ahead and put that up for you to get a sense of how familiar you all in the audience are with the concept of trauma-informed care.
So here we have the question, the poll. I am familiar with the concept of trauma-informed care. And please choose one of the 3. Never heard of it, I've heard about it, or I'm very familiar with it. I'll give you guys just a little time to plug those answers in.
Had an early distribution of third, and it appears I've heard of it as gaining ground.
Awesome, give you just a few more seconds. All right. Let's see if we can see our results now.
That's great. Thank you all for participating in that. So it looks like about half of the audience has heard about trauma-informed care, with an additional 20% who are very familiar with it. So apologies to that group for whom this will be reviewed. But importantly, a third of y'all, just about, have not heard of it. And so we'll take a minute here to talk about the concept of trauma-informed care and what it looks like and why it's important for the patient with addiction. So again, thinking about the characteristics of these women in the Horizons program, who likely represent broadly what women with substance abuse disorders look like. You want to think about 6 key principles, and there's a hyperlink at the bottom of this slide, which you all will have in your packets and your handouts. I encourage you to go to this website and learn more, where you can also download additional resources beyond what we've attached to the program today. And those are tools that you can use with your patients or with your coworkers to help gain a better understanding of these concepts. But the 6 key principles that you want to know about trauma-informed care is you need to create an environment for the patient where her safety is paramount and she does not feel threatened in any way, because whether it's in previous visits with doctors or other healthcare providers that she's felt unsafe, perhaps her first experience with opiates with the prescription after a tooth abscess or a broken ankle, and that led her down the path of addiction, or perhaps it's other environments like her childhood or her home or her domestic relationship where she doesn't feel safe. So making sure that the patient feels safe in your environment, that she can experience trustworthiness and transparency with you, that you can talk with her about her substance use in a non-judgmental and open and understanding way, so that she can, perhaps for the first time in her life, develop a relationship built on trust with you, the person caring for her child or for her. Making peer support available is another key foundational principle for trauma-informed care. So the white-coated physician or the highly skilled therapist is a professional who brings a particular set of knowledge and expertise, but a peer who has gone through what this other patient has experienced is equally valuable in helping her see that maybe there's some light at the end of the tunnel, or some value to her spending time in your office to get the treatment that you can offer. And so figuring out a way to embed that peer support in your practice can really add value to what you're doing for these patients. You want to have a collaborative environment with some shared decision-making or mutuality, where whenever it's possible, you give the mother or the patient, if they're old enough, an opportunity to make a choice about how you might walk down a particular treatment pathway. And this is not unique to trauma-informed care. I think it's a good model for care in general. And the example I use when I'm teaching pediatric residents in our general clinic is you ask a child which ear they want you to look in first, not for permission to look in their ears. Because if you ask for permission and you're not granted, you're really stuck. But if you give them a little bit of control, and they say, well, my right ear, why don't you start there? They're more likely to tolerate that exam. And so the same holds true with these patients. Give them some opportunity to have control and feel like your partner rather than your subject. That leads to the next key principle, which is empowerment. And so giving them voice and choice, helping them understand how they can be the real driver of their care. And then lastly, you need some awareness of cultural, historical, and gender issues. And so I'm particularly sensitive to this as a male physician, working with obviously with the mother's female patients, that I present myself in as non-threatening a way as possible, and am particularly sensitive to any issues they may have around gender, but also cultural and historical issues. So understanding where someone grew up, where they came from, or the background of how their cultural or demographic group may have been treated is an important principle as well. The SAMHSA, the Substance Abuse Mental Health Federal Agency, talks about how to have this as a programmatic or organizational or system level implementation. And so just making sure everybody in your organization realizes the impact of trauma, and the perspective from the shoes of someone who's experienced trauma when they're working with patients in this setting, recognizing the signs and symptoms of trauma in their patients as well as family members and others, so that you can identify when someone may be in an uncomfortable situation because of their past experiences with abuse or maltreatment, and that you can respond to that by teaching yourself about trauma-informed care, but also writing it into policy and standard practice in your workflows. And then really, and I think this is probably the most important message on this slide, we have to actively resist any contribution that we might have as a doctor, a therapist, or an office, or a practice, or a system to re-traumatize or trigger these patients. And so being extra careful to not create a situation where trust is lost, safety is compromised, or that sense of collaboration and trustworthiness is threatened, is critical. One of the things that we pay a lot of attention to in our hospitalized patients when the babies are born is making sure that all of the staff who go through the room of that patient have a basic understanding of how we approach this population and what sort of language we use and what sort of language we avoid, so that one nurse or one doctor going in and misphrasing something, even without ill intent, can undermine months of work towards establishing trust. And so going forth, for those of you in the third who hadn't heard of this, I would really encourage you to go to this website and read more about this. There's a lot of evidence supporting this as a valid and evidence-based approach to care. And for those of you who are doing it, kudos. And perhaps you can find some resources on here as well to share with your colleagues. And those of you who are more expert in it, I would encourage you to become local champions if you're not already, and find the folks who need some more experience with this, and open their doors to it so that they can learn more about trauma-informed care. Okay, so moving on to breaking the cycle of addiction and thinking about ways that we can help a child born to a mother with a substance use disorder or being parented by a mother with a substance use disorder not grow up to have the same experience when they become older children, adolescents, or adults, to fall down the same pathways or follow down the same pathways that lead to addiction. And there are several examples I'm going to focus on the next couple of slides. And by no means am I suggesting that you go out and employ all of these, but I hope by highlighting a couple of examples, folks can perhaps walk away with one that looks like it might fit into your treatment paradigm or your patient population, or one that you could share with colleagues in your community who maybe need some more resources to give to families. So the first of those programs is called the Triple P, or the Positive Parenting Program, and it's really summed up best. And again, there's a hyperlink on this slide that will take you to their website where there's lots more information, both for healthcare providers, but also for parents and families. But they outline a 5-step process to promote positive parenting in these mothers who, in all likelihood, did not necessarily experience this kind of parenting themselves growing up as children. And so they do not have or did not experience the role modeling of positive parenting that will help them understand how to be the best possible parent to their child. And so the first step is to create a safe and interesting environment. So you don't want to have outlet cords and tables with sharp edges or glass or other things that the toddler can have access to. But it also needs to be interesting. And so some things that they can get to, and it doesn't need to be fancy like the waiting room in the private practice pediatrician's office in your community. It can be simple things like Tupperware containers and wooden spoons that the child can play with and keep themselves busy and distracted and engaged, giving the parents some time to do the things we all have to do as parents, whether that's cooking some dinner or using the bathroom or making some phone calls or paying the bills. Having an opportunity that the child can safely entertain themselves and just play freely will give them some freedom as a parent. And again, that doesn't need to be fancy or expensive toys. Another step, the second step highlighted here, is to create a positive learning environment for the child. And so this is perhaps sort of second nature to some of you on the call today, perhaps something that seems like common sense even, but again, in a person who's not experienced this type of parenting in their own childhood, highlighting this can be important. And so praising behaviors you like, telling your child you love them, speaking nicely to them, getting away from baby talk as they become toddlers, and sharing your experiences, or what I call narrating life with a toddler. So, hey, I'm just up here cooking some mac and cheese, or I'm going to go make a phone call real quick, or let's go to the grocery store, or little things like that you can do to just create a language environment around the child that helps them understand what's going on in their world. And then by praising those positive behaviors, you'll generally see more of them. A corollary to that, and the third step in the Triple P program, is using assertive discipline. And so this is summed up best with the word consistency. So setting clear rules or limits or expectations, don't run in the street, don't pull the plug out of the wall, those kinds of things. And then having age-appropriate consequences such as timeout or other brief, time-limited consequences that are consistent. And that is all complemented again by praising good behavior. And so the child who does what the parent hoped and expected that they would do gets positive feedback for that. And positive feedback begets more of the same behavior. And then again, another corollary and the fourth step here is having realistic expectations. And again, this mother may not know what a 2-year-old is capable of. And so helping her understand the developmental capacities of a child of that age, and at the same time acknowledging that we all make mistakes. I can not ever have enough fingers or toes to count mine, but acknowledging those and moving forward, and even acknowledging them, especially as children get older, is a really important part of positive parenting. And then lastly, taking care of yourself. And this is something that the Horizons program spends a lot of time on. And that's peer counseling, talking to other parents, finding time for regular exercise, and then using your community of support around you, whether that's a grandparent, an aunt, or a babysitter, to give yourself a break and have some so-called me time is key. So these 5 simple steps, again, may seem like common sense to folks who grew up in an environment where these were reflected, but for many of these women, this was not at all what their childhood was like. It was filled with inconsistency and toxic stress. It was filled with maltreatment or neglect, and so they just don't have that lived example of what this would look like. And this program has lots of tools that helps them develop this skill set and use it with their own children. Another important set of concepts to think about with parenting in the setting of addiction is attachment, and how attachment between mother and child or parent and child relates to child outcomes. So this is a model that's been published that shows avoidance and anxiety about parenting in a grid with the sort of different types of outcomes that can happen. And so if you have a parent who's low avoidance or responsive to their child and engaged with their child and has a low anxiety level, then that is going to lead to a secure attachment. And the sort of opposite ends of that extreme of a high anxiety environment and high avoidance, a parent who's not quick to respond to their child or avoids their child when their child needs them, is going to create a disorganized sense of attachment and really make it difficult for that child to understand how the world around them works. And so, of course, what we want to do is try to create a stable environment where if there's anxiety, it's being addressed through education or treatment or other scaffolding and supports around the mother. And if there's avoidance, there's exploration of why that is and modeling of how going to the child can actually improve attachment, even though it might be scary for that mother to do that because she feels like she might not know what to do. And then obviously the unstable environment where addiction is not treated. Often there's anxiety in patients who are not in remission with addiction, and they might have a lot of avoidance because they're either not in a capacity to care for their child, or they're unwilling to or unable to based on where they are with their addiction. And so we want to move towards that top left part of the grid, realizing that that not everybody is going to be able to do that easily, but all the support that we can provide to a mother to help her find that quadrant of this grid can be really, really empowering. And so there's additional research that supports that addiction is associated with non-secure attachment. And this slide is not meant for me to read, but it's meant for you to have in the handout. And be able to reference as you think about, again, your own work with these families. But just know that in the setting of addiction, non-secure attachment, either in that patient's own personal history or their own work as a parent, is highly associated and higher risk. And so be aware of that and again, be thinking about moving towards that secure attachment. Okay, and so we're going to do the third poll here as we start to wind down today's discussion and leave time for questions. And so if Scott can open that up for us, and if you all can take a second here. We've had 90% voting here in less than a minute, so thank you for your engagement on that. And so the last point I'm going to make here is in breaking this cycle of addiction is the importance of normalizing typical or healthy infant and child behaviors in the population of patients who had neonatal abstinence syndrome or at risk for it. And so helping mothers understand that not all they're seeing in their child is necessarily or even at all related to their baby's particular symptoms. And so this question, Scott, did you read it?
I did. I haven't read it yet, but it says I've been a parent or loved one to a colicky baby, and so they can choose yes, no, or not sure. We've had about 85%, so Great. I'm going to go ahead and close that, and we can view the results.
Perfect. So this is interesting. This is about a 50-50, which I think the statistics for colic are that it affects a little bit more than half of patients. So this may just be a nice normal distribution based on the folks that we have. But the point of that question is really to get at the message that all babies cry. And crying and even irritability does not mean neonatal abstinence syndrome. And so I have this discussion all the time with brand new babies and newborns in the first few weeks of life. And it's not uncommon for women to have read that crying or irritability is a symptom of neonatal abstinence syndrome and their baby's crying, therefore they have NAS. But again, normalizing that crying is something that all babies do is a really empowering step that we can take. That this is just your baby's crying, she's hungry, she has a dirty diaper, or I'm making her mad by examining her heart and her lungs, or she doesn't want to have her shirt put on because she's cold until it's on. And that's okay. And so helping them cope with that, helping them respond to that appropriately by then soothing the child and helping them calm down after the irritating event, such as having a diaper changed, is much, much more important and a valuable lesson to that mother than ticking it off on a score sheet as a component of neonatal abstinence syndrome assessment. And so helping women understand how those behaviors overlap normal and help them view their child as healthy as opposed to one who is sick. Helping them understand that temperaments vary and some babies are easier than others. That's true. Anyone who's had more than one themselves, I think, has probably understood this lesson. In terms of other ways of empowering women, again, consistency. I think if there's one message that a woman can leave a PT appointment with a 9-month-old or a social work evaluation or a doctor's visit with, is that consistency is her most valuable tool in helping her child navigate the world around her. And that if we empower mothers with confidence and knowledge, we'll be able to help them be the best possible parents they can be and have the healthiest possible child they can have.
Just because of the way that.
I wanted to end up here with some local resources. And again, each of these has a hyperlink that will take you out. The Family Support Network of North Carolina is a group that focuses on children with special health care needs, and depending on the chapter in your region, babies who were experienced NAS as newborns may fall into their catchment, and that may be a group that you can reach out to and partner with to try to find peer support or other community-based help for these families. The North Carolina Pregnancy and Opioid Exposure Project, based out of the School of Public Health here in Chapel Hill, is a really valuable resource with lots of patient education and provider education materials that you can use at your institutions locally. CCNC, or Community Care of North Carolina, has the Pregnancy Medical Home Project, where women are assigned care managers and have a host of resources made available to them. And so opening the door to treatment and helping them understand that treatment is their best path forward if they're struggling with addiction and find themselves pregnant is available and there for them in their local community. And then lastly, the Addiction Medicine Updates tool has an algorithm for screening and an approach to talking with families with great examples of language to use that's non-judgmental and supportive, and helps open the conversation in a way that will have that trauma-informed feel to it when you're talking with families. There's also a suite of other postnatal evidence-based tools that are used at Horizons and available on the internet. These I highlighted last time as well, but I just wanted to put here again at the end of today's talk to make sure you had them. There's an additional attachment-based parenting program called Circle of Security. There's another one called the Nurturing Parenting Program, a leaner program called Hug Your Baby, and then some information about child-parent psychotherapy, or that dyadic modality of working with moms and babies together on their individual needs to focus on attachment at that hyperlink. And so all of those are there for you all to jump out to and learn more. And I hope you'll go away from this, if not having a greater understanding of some of these issues, at least having a sense of where you can go to learn more and get more than a superficial exposure to some of these concepts. And so with that, I'll end on some of the outcomes. I highlighted a different set of these at the end of the last talk, but this is overall a really positive experience. So nearly 80% of the residential women in the Horizons program, in that same cohort that I outlined before, were employed when they left the program. So not only was their substance abuse disorder in remission and was their baby with them and healthy, like I talked about last time, but they were employed and out working in their community and enriching themselves and supporting their child. And so that's really a spectacular turnaround from where they enter the program. And nearly all, 95%, had at least maintained or typically improved their CPS case status. And so that's retaining custody of their children, having closure of a case, or some other progress in terms of the support they're receiving from the state. And so really, really impactful outcomes that we can have by treating substance use just like we do any other medical diagnosis. We don't throw people out on their own to manage their diabetes or their asthma, and we shouldn't be doing that with substance use disorders. And I think this is evidence that approaching addiction like we do those other diagnoses is really successful and ultimately leads to better outcomes for our patients. And so with that, I think we can open up to a couple of questions, which Scott is going to moderate for us, and I'll try to answer a few here in the last few minutes that we have. And then any others we can answer in writing. So if you get something down in the chat box, we can respond to those as well. Scott.
Fantastic. So the first question that we had was from Janine, and she asks, how do you handle mothers who decline opioid treatment?
So medication-assisted treatment for their opioid use disorder. So MAT is one component of treatment of substance use disorders. And so depending on the substance of choice, depending on that patient's past experience with buprenorphine or methadone, they may have very strong opinions that it doesn't work for them, and they very well may be right. And so in those situations, you obviously have to gauge safety first. And make sure what she's doing is not putting the child at risk. But if she's engaged in psychiatric treatment, for example, that may be getting at the root cause of her addiction and helping her outcome, having a different level of supervision perhaps may be needed if there's a high risk or high amount of concern for relapse. But engaging in some form of treatment is really critical and is what the CPS workers are going to set forth as a minimum standard. But engaging in other forms of treatment besides MAT is at least a starting point.
Fantastic, fantastic, thank you. Sherry was asking, does Horizons screen for adverse childhood events, the ACEs? And if so, what consultation does the mom receive after the completion of the ACEs score? And do you guys track them?
Yeah, that's a great question. ACEs, or adverse childhood experiences, have been shown in the last several years to be extremely impactful on adult health outcomes. And so if you experience trauma in early childhood, whether that's sexual abuse or physical abuse, even hunger or homelessness, you're more likely to have diabetes and other adult diseases when you grow up. And so screening for those is really important. What we're effectively trying to do in this program is prevent them in this second generation. I don't know the extent to which the mothers in Horizons are screened for ACEs, since my work is more so focused with the children. But I can do some digging for you and ask what those outcomes would be, and work with Scott to get you connected to somebody or get you some more specific answers to that question. But yes, it's really key to be screening for ACEs in both the mothers, and then to be looking at ways to prevent those in the children.
Sure, and about how long do they stay in the Horizons unit?
Great, so the Horizons program, the typical stay for moms is around 18 months, and so many come in at the beginning of a pregnancy when they discover they're pregnant and realize that their substance use disorder is now no longer just impacting them, but their unborn child, and they continue through the pregnancy and for the first year postpartum. Other women will come in with infant or young child who's already been born and they're not currently pregnant, and they typically stay in at least a year. But we that's what we aim for. That's what Horizons aims for, and some women end up staying a little bit longer depending on their treatment needs.
Thank you, that's awesome. So Kylie asked a question, would a baby with NAS possibly internalize dysregulation and present as under-responsive, like hardly ever crying, sleeps long stretches, and not wanting to eat?
That's a great question, and one that highlights a couple of slides ago that temperament can be highly variable. And so one of the challenges I face when I'm working with these kids as they get older is, which behavior is maybe a sequelae of NAS and which is just who this kid is, right? The so-called lazy eater, or the more introverted or socially aloof child versus the more active, irritable crying, kind of typical presentation that we might have in our minds. I think that's probably very difficult to study, but certainly you would want to think about any of those behaviors in the context of the history of NAS. One example I can give you where that was true for us was a woman who was away for a weekend with her then maybe 6-month-old for a family wedding or a similar type event, and she came back and the child was frankly sedated, and so we had to be pretty concerned in that case that perhaps the mother's substance abuse had slipped, or perhaps the environment that family situation created was one that maybe had an adverse effect for the kids. So I would say always assess those things in the context of, could this be relapse? Could this be related to substance use or neglect, for example, in some way? Or is it perhaps within the spectrum of normal? And the thing we need to do is teach mom how to differently engage that child and interact with them in ways that will promote good developmental outcomes.
Fantastic. And I think we have time for one more question. Christina asked, how does the Horizon program work in counties outside of the University of North Carolina.
Right, so Horizons is based and was founded in Orange County here at the Medical Center in Chapel Hill. It has since had various expansions that have also contracted at times into Wake County, where we currently are active. They currently are active treating moms. There has been outreach into Alamance County, and there's some ongoing work at the state level to try to replicate this model in other parts of the state. We recently hosted MAHEC, the Mountain Area Health Education Center OB group here in Chapel Hill, to share with them some of the approaches we have to NAS treatment, as well as the treatment model that exists for the mothers. And so there's active work going on to try to replicate this model across the state. If it's something that hearing today's presentation makes you wish you had something like this, then talk to the folks in leadership roles at your institutions or in your community, and make sure that they're aware that this program exists, and that the state is in the process of trying to spread this model of care, which has shown to be so successful here in Chapel Hill.
Well, thank you so much, Dr. Seashore. This was great. The last two sessions have been wonderful. I think we're about out of time. I just want to remind our audience to please remember to wait until the webinar closes and fill out the brief 5-question survey. PTs and PTAs must provide their name, credentials, license number to receive credit for the course on question number 5. Everyone else can just type NA in the box and complete the evaluation. Also, if you go to www.mahec.net and log into the MyCE area, you will find all of the handouts and resources for both sessions. There you can do a course evaluation, and at the completion of the evaluation, you'll be able to print or save your certificate. We will need about 24 hours to tabulate your credit hours on your certificate. So at this time, I'd just like to thank the Leo M. Croghan Foundation and Dr. Seashore for making these webinars such a great success. And hopefully we can do something like this again in the future. Thank you so much.
Thank you all very much.